Morning, everyone. Today's case, a 17-year-old male patient presented us with history of left testicular pain associated with lower abdominal pain of 1 day duration. The pain was acute in onset, which was moderate in degree and continuous in nature, with a partial relief with the use of painkillers. There were no aggravating or relieving factors. There was no associated fever, nausea, or vomiting associated with the pain. No history of any preceding trauma, no history of any lower urinary tract symptoms. Patient had a similar pain around 10 days back, which was managed symptomatically, and he did not get evaluated further for the same.
Two things here. Whenever there is testicular pain of this nature, just saying no lower urinary tract symptoms is not enough, because you should show the examiner what lower urinary tract symptoms you're looking for. What LUTs are you looking for?
Sir, especially if I'm suspecting any epididymoarthritis, sir, any burning...
No, you are suspecting a whole lot of things. Specifically, what are you looking for? In terms of LUTs, what LUTs are you looking for?
Sir, any burning micturition, sir.
Okay.
And... Pain while warding also.
Okay. Painful micturition, burning micturition, okay. See, this is how you'll get caught in the exam. If you're thinking of testicular pain, you're presenting it as testicular pain, or one of your differential diagnoses will be an infective cause.
Yes, sir.
Right? So, symptoms pertaining to urinary tract infection and causes of urinary tract infection should figure in your presentation to tell the examiner that, yes, I have thought of all this and none of this is present.
Yes, sir.
Do you agree with me?
Sir, yes, sir.
Okay, so the commonest cause is a UTI. So, features of UTI, if you say there is no burning, there is no frequency, there is no pain when passing urine, you've covered one aspect. The second aspect is urinary tract infection due to obstruction. So if you say patient's voiding well, has got no difficulty in passing urine, then you know that obstruction is ruled out, UTI is ruled out. When you ask this history, you might discover that the patient actually has some of these. He thinks it's not important.
Yes, sir.
Okay.
Yes, sir.
Imran, if you are taking this history in emergency, and this patient says 1 day history of testicular pain, would you improvise that statement? Because your differential diagnosis is what else? You have told about epididymoarthritis. What else is another differential?
Sir, could be testicular torsion, sir.
Yeah, who is discussing? Sorry, I mean.
Saurav.
Okay. Yeah, we'll ask Saurav here.
Good morning, sir.
Sir, it can be a testicular 17-year-old male with no history of trauma, no history
No, you don't know that.
testicular torsion.
So in that history of 1 day duration, would you like to specify anything more in that?
Sudden onset.
Not the onset.
Sir, he has come to you today morning.
Yes, sir. Yes, sir.
I have this pain from yesterday. So Dr. Prabhu is asking you whether you would like to dig further about the duration of the pain.
Yes, sir. I would like to ask the onset timing, sir, and how much has it passed, the duration of onset, how much it is passed, because in cases of torsion testis, there may be, the time lag would be an important aspect.
What is that?
Duration of onset, duration since onset.
So how much you are concerned, how much you are looking at, what timelines you are looking at?
Sir,
Yeah, he says 12 hours, 6 hours, 2 hours. So what are your timelines?
Sir, if the duration is more than 6 hours, then we'll be more concerned about the chances of, if it is a torsion testis, chances of viable testis will be less. So that duration is important.
The salvage. So
The
if
salvage.
if there is a actual torsion,
Yes.
you would like to operate as early as possible, preferably within 4 hours.
Yes.
So you just say one day, you don't ask for some test. You have to be very quick if you are suspecting torsion.
Yes.
What does this history of similar pain 10 days tell you?
So it may be suggestive of he had history of any partial torsion. So
what history would you like to ask about that? Or would you say, okay, 10 days ago, it doesn't matter now?
history, sir, would be the position of the testis since childhood.
No, don't go so far back. He says 10 days ago I had it. Does what happened 10 days ago interest you now, or is it that, okay, it happened 10 days ago?
The partial was the pain relieved, and was the following pain they were swelling in the testis or redness
I think you're missing the point. Again, when did the pain start? How long did it last is very important.
Yes.
Okay, clearly he's received something, it has been relieved. That's not so important now, because you want to know again whether it could be torsion the last time also. Correct?
Yes, sir. Yes, sir.
What is the usual age of torsion? I mean, we're still in the history. We'll come to that later. So, can it be anything other than these two, what we discussed about epididymoitis versus torsion? Can it be anything else?
Sir, it can be a CA testis, but it won't be with the acute onset.
We are talking of this case. What else is possible?
Inguinal hernia can also.
Inguinal hernia, acute onset pain, unless it's got obstructed today. Okay. CA testis, if there is a sudden hemorrhage in that and sudden increase in the size, may have pain. Fine. And you see how I'm qualifying my statement. You're saying CA testis, then inguinal hernia, then allowing me to think that you are thinking in those times. Anything urological which can present with left testicular pain?
Say history of urolithiasis with suspected VUJ calculus can also present as a testicular pain.
VUJ calculus.
Yes.
Right.
I have no other point.
Yeah. So what do you want to examine in this patient?
The local examination, I'll start with the local examination. With the lie of the testis, the tenderness, and the.
How will you check the lie of the testis?
So it's a horizontal lie or a vertical lie. In case
how
of
will you
torsion,
check? I get the point, but how will you check to understand what the lie is?
Yes. In cases of torsion, sir, there is
Again, when you are asked this question,
clapper.
and when you present examination, you begin with inspection, and your examination will begin with the patient standing, right? All
Yes,
this height difference and lie and all that is better made out with the patient standing. Similarly, what other symptom will help you differentiate the cause of pain, or whatever sign will help you differentiate?
Yes,
You're looking at redness, you're looking at lie, you're looking at position in relation to the opposite testis. What else?
On inspection, the scrotal skin changes would be appreciated.
Okay.
Any inguinal swelling can be made out if
Okay.
a cuff impulse. And
a patient with testicular pain, presenting with acute testicular pain, will you make the patient cough?
no, sir.
Then how will you check for inguinal swelling? So don't put in something which can get you into trouble. Is cough likely to aggravate the pain,
Aggravate
or it makes no difference to the pain?
Sir, it will aggravate it, sir. The cremasteric.
So do you want the patient to feel worse? No, you don't.
No, sir.
Right? Okay, what else? What
The
other?
Yes, sir. The meatal examination would be necessary if there is any obstructive symptom. If we are suspecting to be epididyma or carti, a meatal examination would.
Sorry?
Meatal examination would be suggestive of any obstructive.
No, you have the patient standing in front of you. You're looking at the testes. I think you missed that point completely. Before you do anything, you will ask the patient to expose the testes in a standing position. You'll drop the pant, or you'll take off the trousers or lower the shorts or whatever, and you will examine the patient standing. Please remember, the examination has to begin with the patient standing. In the exam, this is a very common mistake people make. You don't make the patient stand and get into all kinds of trouble. Now the patient is standing in front of you, okay?
Yes, sir.
And you can see his scrotum, you can see his lower abdomen, and you can see his upper thigh. Now tell us, what all will you inspect and what signs will you elicit?
An inspection, sir, the differentials would be ruled out. If there is a...
Not ruling out, Baba. Tell us signs. What signs will you look for? There is inspection, there is palpation, there is percussion, there is auscultation. So when you inspect, what are the things that you will look for? Dr. Prabhu will be very upset with you if you present like this.
One, I don't think anybody examines now this standing.
अब इंस्पेक्शन में बताइए क्या देखेंगे आप क्या देखेंगे
One Karthik can tell him the mic is not working.
Yes, sir.
No.
Please tell us. Hey, you'll fail at this stage, man, in the exam.
Sir, a high riding test is on the side clapper.
What is okay? Again, when you talk about inspection, I'm going to MBBS level surgical examination. You will first look at what is obvious. There is no high riding. What's the first thing you see when you expose the scrotum? You see the scrotal skin. You see the penile skin. You see the surrounding skin, correct?
Yes, sir.
So what will you look at in the skin?
If any redness or...
you will look for signs of inflammation. You will look for erythema, you will look for edema, and you will look for any ulcers, any discharging sinus, correct?
Yes, sir.
And you look for surrounding skin. What else can you find on inspection? You may or may not, but you may find something else on inspection. Don't now think of this diagnosis. Think in general. Person has come with testicular pain. You're inspecting the patient's scrotum in a standing position. You have looked at skin. You have looked at surrounding skin. What else can you look for? Or what else may you find which is obvious?
What is the most important characteristic of the scrotal skin?
Sir, yes, sir.
Yes, you have not mentioned that at all. The first thing you look at is the rugosity of the scrotal skin.
Yes, sir. In cases of signs of inflammation, sir, the rugosity will be lost, sir.
It's true, but what you said was in reverse. You said that I will look for signs of inflammation. if you had said that the first thing I look for is scrotal rugosity, and if that is lost, then it will indicate to me 1, 2, 3. Number one, before the scrotal rugosity, the next thing you look for is whether both the testes are normally seen there. One, sometimes you can find that one testis is hanging a little bit lower than the other. Then you can look for varicocele. You can see sometimes obvious varicoceles. You can see a bulge in the inguinal canal in some of these patients just because there is an associated hernia. There are so many things. If you go step by step, you can answer this question as Dr. Mohan says, MBBS stuff. Don't think that it will not be asked. That's the worrying thing, Although this is a national board, a higher level exam, suddenly the examiner can ask you something that is very, very basic and which you have done only in MBBS. So don't get put off by the fact that that's being asked. Don't think you're going to be asked molecular biology. That half of the fellows don't know anyway, so it's all right. So you're going to be prepared to answer these questions. Go ahead, buddy. Hello?
Saurabh, you have to keep talking. No,
Yes,
please don't change the slide. Go ahead, was for Saurabh. He has to tell us what he will look for and what he may find. He'll have to tell us what he may palpate for, how he'll do the palpation, what he may find. Whether an auscultation is necessary, percussion is necessary.
Oh.
Sir, on examination, on inspection, I will look for sign to look for loss of rugosity, the presence or the absence of the contralateral, the development of the contralateral scrotum.
See, not development. First thing you look to see whether you can see the testes or not.
Yes.
Development you can't make out on inspection alone. Stick to what testes you're seeing, Saurabh. Then you can go to the other side. Or you want to say both are present and then come to this side, that's also fine. But don't go beyond that. Is there anything you can see on inspection? Can you find some worms?
So, inguinal scrotal swelling, presence of varicocele, that can be.
Why inguinal scrotal? Varicocele is scrotal.
Yes, sir. The hernia, sir, I'm speaking about the varicocele, the inguinal hernia.
So, you first mention the bag of worms, no dilated veins, no thrombosed veins seen on the surface. Because one of the things which can cause pain, which the patient thinks is coming from the testis, is something happening to the scrotal skin, which you missed out in the diagnosis, but that's all right. Then you look to see whether there are dilated veins, the bag of worms appearance. And then you go up to the inguinal region to see whether there is any inguinal bulge or an inguinoscrotal bulge. Correct?
Yes, sir.
You already mentioned the opposite testis. If there is any abnormality with the opposite testis, then you might want to examine the opposite testis also further. You might want to see whether there is an inguinal bulge on that side where the testis is missing. At this stage, you move on to palpation because you want some more details. So what is the first thing you will do on palpation?
On palpation, I would like to
First thing you will do.
So I'll palpate the testis and I'll
He'll howl. He'll howl and scream. You would know this if you've examined a torsion.
Sir, local rise of temperature, tenderness.
Right. If you look for tenderness, he'll scream. What is that one sign which will help you differentiate, if it is present, torsion from an inflammatory condition?
Sir, cremasteric reflex. Sir.
Where is the cremasteric reflex, Baba?
On palpation, sir.
There is something we say, relieved by elevation, not relieved by elevation.
Yes,
correct?
sir. Yes, sir.
So that would be the next thing you look for. Because you can do the elevation without causing pain. If you start palpating for the epididymis and other things, that fellow will scream. You will also know how tender it is when you palpate for elevation And depending on the tenderness you elicit, your examination is going to be that much more gentle. And you will spend that much more time because you can't straight away go to palpate the cord and the epididymis and everything else.
What is this elevation test? What we are talking about?
So in cases of epididyma or inflammation of the testis, the pain is relieved. However, in cases of torsion, the pain increases because the torsion increases. So that's,
May increase or may remain the same.
yes, sir, may or may not.
Yeah.
Name I don't remember. So
Don't stop.
So after the elevation test, I'll look for the cord. If we can palpate the cord, any knotting can be appreciated or not, which may be suggestive of a torsion.
Okay,
test.
don't. That you don't do. Just say, I will look to see whether there is a kink or a knot or a thickening of the cord that I can make out. Okay, unlikely you can, but you want to put it and stick your neck out, do so, but don't go beyond that. What else?
Have you heard of blue dot sign?
Blue dot, yes, it's ultrasound based values.
Let's say it's a very fair boy. How can blue and red be appreciated on ultrasound? I said it's a fair color, not a dark skin. Fair color.
Torsion of the appendix of the testis can give rise to a blue dot, discoloration typical of torsion of the appendices of the testis.
Yeah, that's also inspectory findings. One of the differential is not only these, the big things, the smaller things also. The patient has come with pain, and you find that there is torsion of the appendage, where the treatment is much simpler. Okay. Shall we proceed, sir?
Yeah.
Prabhu, you lead the discussion. Go on, you are on the spot. Please proceed.
Imran.
Dr. Prabhu will lead the discussion.
So he had a BMI of 15 kg per meter square with a ECOG performance score of 1. Tachycardia was there of the pulse rate 116, which is regular.
Hey, your examination is not complete here. You have to tell us, Saurabh, before they tell you what all you are going to do. See, on palpation, after you've assessed the degree of tenderness, after you've looked at the lie of the testis, after you've looked for varicocele, you'll palpate the opposite testis to see if there is anything wrong with the testis. And if you can assess the sides of the testis on this side, and if the tenderness is not very much, you'll also palpate the consistency of various areas of the testis. This is what comes under palpation. If you find a concomitant inguinal or inguinoscrotal swelling, you look for cough impulse. If it's inguinal or inguinoscrotal, you'll do the test for hernia as indicated. If it's there are no inguinal or inguinoscrotal swelling, you won't do the test for hernia. Fine?
Yes, sir.
You said lie that all that is on palpation. Okay.
Yeah, speaking about the lie of the testis. Yeah, comment on that.
In cases of in epididyma arthritis, the lie would be vertical lie. With however, in torsion, the the lie would be on a higher side, will be elevated, the testis will be elevated, and due to the rotation of the spermatic cord, it will be horizontally placed, and that would help differentiate the torsion test. And they may be may be appreciated, may or may not be appreciated.
Anything more you want to examine?
The other, the normal site has to be examined first, followed by the site which has the pathology. And I would like to examine the penis and the meatus to look if we are suspecting to be, because in cases of late presentation of torsion, there may be signs of inflammation in the scrotum too. So we have to to genital meatus to rule out any obstructive pathology which is causing the epididyma or arthritis.
Suppose you have any torsion, why will you examine when you examine the penis, what will you look for?
Penis, what you will examine?
It doesn't have torsion. You just got this testicular pain and swelling, no?
Yes, sir. In penis, sir, the meatal opening has to be examined, sir. Even in thickening of the urethra, which can be appreciated.
See, talk of obvious phimosis, meatusmosis.
Yes.
There is a cremastic reflex.
So cremastic reflex, in cases of inflammation, generally it is lost. So there are signs of inflammation. The cremastic reflex won't be a useful sign. However, there are incidences when there are no. It's not a short test to rule out the torsion test.
There is a cremastic reflex.
The medial aspect of the thigh is stroked to look for the elevation of the testis. If there is inflamed torsion of testis, so inflamed, the testis won't get elevated, so that reflex can be elicited.
So the local exam.
Let's move on, man.
Yeah, okay.
Move on.
Normal.
My request to everybody, all the residents listening in, please read basic examination of the scrotum from Das, from Hamilton Bailey, from whichever textbook you've got on clinical methods in surgery, and be thorough with it. It is very important for you even in your real life practice.
Yeah, you comment, man.
On examination, the prepuce.
No, don't read. We all can read. Your interpretation.
There are signs of inflammation in the testis with a thickened spermatic cord. With the right testis lying at a higher, with the left testis lying at a higher level as compared to the right testis, and with a short acute onset of pain, my differential still would be the torsion testis, the primary differential.
They have said here that other systemic examination is normal. Let us assume that they found some vague mass on abdominal examination.
Sir,
What happened? Why the silence?
the vague mass, sir, where, sir? Anyways.
In the abdomen. Either they found a vague mass in the abdomen or they found some maxillary lymph nodes, neck nodes.
Sir, it can be a history of lymphoma, sir. It can cause testicular swelling, sir, with acute onset pain due to hemorrhage, sir. The varicocele also can present, but they won't be a thickening of the spermatic cord or tenderness.
Why will varicocele have abdominal mass? Or
No, the abdominal mass will compress the outflow. The venous drainage may be compressed. So I'm saying.
no? What is he talking about? That vague mass. The one you said is lymphoma. Anything else?
It can be a CA testis with an abdominal mass.
Yeah, you talk of urology first and this other things later.
Even your theory that this could be an abdominal mass causing obstruction to the veins and causing a varicocele. Those patients don't present generally with testicular pain. They may have some discomfort. They will find that on examination, most of the time, you find that they've got a varicocele or something like that. And sometimes some very astute patient might tell you, yes, one side testis feels a little heavier or hanging a little bit more than the other. But they will not complain of pain. So there is a distinction slightly between what you said and what the patient presented with. This is primary testicular pain, and therefore you have to address the testis primarily and not anything else. Can you get an inflammatory type of testicular carcinoma? Have you heard of it, or do you know about it?
No, sir. I haven't.
No, that's what Prabhu was trying to get at. You asked malignancy in the testis, and then we talked about something that can be an inflammatory condition, So
you have examined. Let us proceed now. What do you want to do now?
Sir, I'll explore the testis, sir, of the left side. There is if clinical signs are highly indicative of the torsion of the testis, I would like to explore it. The further investigation is not required.
Any imaging? You don't want any imaging?
Sir, it's not necessary, sir. If we are suspecting a torsion testis, the imaging is not necessary to get it done, sir.
Supposing you have the facility, will you get it done or not get it done?
Yes, sir, I would get it done, sir.
So why didn't you mention it? You might as well mention.
Let me ask you put the question slightly differently. Supposing at the time of exploration you find you have to remove the testis, what will you do?
We have it, sir.
Supposing at the time of you have explored this patient.
Yes, sir.
The diagnosis is correct.
Yes, sir.
You told the relatives and the patient, I will explore because I suspect this. You must have some evidence, no, that the testis can be removed. If you have a facility for doing a Doppler, how long does it take to do it?
Yes, sir, we can get it done, sir, if you have a Doppler, sir.
With an intraoperative decision, having not given a consent to remove a testicle for a patient.
Sorry, sir, can't hear you, sir.
You may not have taken consent for an appropriate operative step in surgery because you're not sure. That is why to do an ultrasound or do a Doppler does not take you much time. Anyway, the testis is already, the pain has been there for a while, isn't it? While I do understand that, when you suspect torsion, you don't delay, but doing an ultrasound, a Doppler ultrasound, is not going to cause so much harm, is it?
Yes, sir.
So I think there should be some degree of, in today's world, I think you need to be very careful about certain things and, removing kidneys, removing testes and all that. You should have something up your sleeve to account for this action.
Yes, I got.
This should be one of the indications where you will ask for an ultrasound before you proceed and not wait for the ultrasound to be done. Ask them to come and do it. There are portable machines with Doppler probes available. In a couple of minutes, you can finish. You're not interested now in quantifying the flow and all that. You want to see whether there is flow, no flow or poor flow, and you want to tell the relatives before they give consent that we may have to remove the testis. And they're going to ask you why. Why do you say so? You'll say, look here, there is no blood flow. We'll do what we can, but if we can't restore blood flow, we'll have to take it out.
Yes.
People may not today accept your decision taken purely on the basis of what you find on the table.
Yes, got it.
What are the signs of torsion ultrasound?
On
So was the patient explored? You don't want any other investigations. You want any other investigation?
Do you want any other investigation?
no, no other investigation like such at present.
You don't want to do a urine analysis.
See, all this, you don't have to wait for the reports, but you can tell the lab person to come and draw the blood, take the urine sample. What is the problem? It will come in 1 or 2 hours, let us say. But not asking for it is different and not waiting for it is different.
Many emergency A&D departments, casualties, they have the test strip right there. So they'll do a dipstick test and tell you.
One of the simplest tests to do is a urine analysis. And you'll be surprised as to how many people do not know that they've got microscopic hematuria or they've got 1+ albumin. And then at the surgery, at the time after surgery, you suddenly find that they've got problems because you give them some nephrotoxic agent that's creatinine goes up, urine output drops, and then everybody's running around. You have created an acute kidney injury to a patient whose already renal function is compromised. Probably the world's simplest test, but it's done by everybody, especially people who are going for herniorrhaphy and things like that. I've seen it so many times. I've seen it in large institutions. That's what I'm telling you. You got to look at a call like this. Oh, great, urine output is low. What have you done? You have not done a urine analysis. You missed out somebody who's having a serious illness. I'm talking of India. I'm not talking of the Western world. Okay? These are real life situations here.
Yes, a routine test. I would like to get a routine test done and the urine analysis too.
Will you do tumor markers?
Yes, sir.
Will you do tumor markers?
So tumor markers.
Tumor markers.
No, I would not get a tumor marker done, sir.
Okay, let us flip it. When will you do tumor markers before you explore? Presentation is this.
So before
Presentation is acute testicular pain. And you're exploring the patient. When will you insist on tumor markers being sent before you begin the exploration? Or is it always all right to send it after the exploration, after you finish doing whatever you have to do?
So Before orchidectomy, sir, if
The
if we are
answer is pretty simple. If there is an increase in the size of the testes, if there is a change in the consistency of the testes on palpation, I will send the tumor markers also. However, in an acutely inflamed testis, it might be difficult to assess the testicular consistency and so on. But on exploration, once you have opened the tunica and you find that the testis might be having a tumor, you will draw blood for tumor markers and then proceed with the rest of the surgery. That would be the answer you will give.
Let me just add one more clinical scenario in a situation like this. Don't think that you cannot get an acute episode of pain in a scrotum which has got tumor in it. All right, it can present an inflammatory swelling, it can present acute pain. And you must be very, very sure that you don't land yourself in trouble. Just remember, many years ago, there was a surgeon called Gordon Taylor, Sir Gordon Taylor. He described this condition, inflammatory hurricane type of testicular carcinoma. Right? That was an embryonal carcinoma. Those days we didn't have any classification. And this would be a rapidly progressive thing and very inflamed. In my urological career, I've seen 3 patients. And that's quite a number actually. Quite a number is inflamed. And one was, actually they bled inside. One was a seminoma, the other was an embryonal carcinoma, and the third one presented a young man as an epidermolysis. So these things can happen. So you must be very careful. Think of other things also. I can understand that yes, your mind is focused on testicular torsion here and that you want to quickly save this testis. But just be sure that you are not missing the boat on some of these other clinical conditions which can happen.
yes.
So coming back to Dr. Vinod's question, what signs you were looking in Doppler?
Doppler, sir, in case of torsion, the resistive index will be high. There will be no flow appreciated in the testicular. However, the albuginia may show due to the inflammation.
If you've seen and done a Doppler, Saurabh,
Yes, sir.
the first thing that you'll hear is the sounds. The next thing you'll see is a color rendition of the blood vessels. All the measurements and everything come after that. So you begin from there. Let people know that you know about scrotal Doppler, you know about how it's done and what to look for.
Yeah. You're not serious. You're not serious.
The flow would not be appreciated in the sir.
Okay, I'll just ask you one question in this. What happens to the testicular veins in torsion?
Sir,
What is the Doppler characteristic you're likely to find?
they will be collapsed. No, sir, I don't know. Sir.
You'll have to read. You see, the same twist which causes the artery to lose its blood supply will cause venous congestion, right?
Yes.
So you'll find a distended, non-pulsatile vein. You get it?
Yes, sir.
There is also another test which all the sonologists do when they do an ultrasound on the scrotum. And that also will be absent here.
What happens when they do a Valsalva?
There is a distensibility of the venous complex of the veins. However, the
In torsion,
In torsion, it won't be there, so it will be absent, sir.
Yeah. Okay, so that's totally done during scrotal Doppler. So you must know what happens during Valsalva, what happens at rest, what happens during Valsalva. And supposing it's an early presentation and you have attempted detorsion or you think there is a spontaneous detorsion, what are the likely findings? These will be standard questions. Okay, let's proceed. I think we're coming closer to the end of time.
Just what 219. Rani never come.
The X-ray nights. Still, yesterday we have to repeat twice. Today night we have 100.
Now, what do you find here, Saurabh?
No.
Sir,
Yesterday we didn't feel it. Yesterday till morning we have but we are when we have like
the Doppler, the epididymal shadow can be appreciated in the midline side in the left testis. There is a minimal sign of...
Listen. A Doppler is done for flow.
Flow, sir. Yes.
So please mention flow. Everything else can wait. You get it? Grayscale ultrasound is done to look at various structures. A Doppler ultrasound or a duplex scan is done to look at flow and flow velocities. So please deal with that.
So, say static. Can we appreciate with flow?
Read up, please.
Yes, sir.
But this clearly you're out of your depth. Okay, look at the Doppler patterns in different testicular conditions and how blood flow changes progress in torsion. What happens in varicose, what happens in an infarction. Okay?
Yes, sir.
We might as well go to the report because I don't think he's familiar with scrotal Doppler.
So the Doppler shows a left distal cord to be twisted left distal spermatic cord with vascularity appreciated in the parenchyma, testicular parenchyma, and it is going to be a partial torsion with minimal peritesticular fluid, sir.
The parents are still more confused now.
My parents, even the doctor is confused.
No, sir, I will explore the patient, sir. The testis has to be explored.
That's okay. But what's your diagnosis? What's your working diagnosis? What will you
Working
explain to
diagnosis
the
is,
relatives? What is your plan?
I'll explore the left testis. If there is any, if the torsion is there and if the testis is viable, I'll do an orchidopectomy. Yes, sir.
Patient's father, mother, sister, brother, uncle, somebody sees the Doppler report and says, sir, they're saying blood flow is normal.
So in cases of torsion, also the flow in the tunica albuginea can be appreciated as a flow in the.
This is not tunica albuginea. They've said testicular vascularity intratesticular.
So the partial torsion can further cause
A relative says, sir, you are saying no blood flow, there is blood flow. So why do you want to operate? You want to make money. So you need a stronger scientific argument or reason by which you can convince him.
So he had already had a history of pain 10 days back. He again had a pain.
Sir, that pain also might be like this only, sir. Blood flow was normal. Then see, 10 days nothing has happened. What will happen now?
The testis is prone.
We will wait and watch, sir. There is no need to operate. That's what they're going to tell you. Size also is normal, sir. Everything is normal.
So testis is prone for torsions and
Is there anything in the dorsal report, in the Doppler report, which will help you in telling them why you need to operate?
So, left distal spermatic cord appears twisted, sir.
Yeah, so that is what you'll be pushing for, isn't it? In your own mind also, you're not clear what this twist means. But the fact that the cord is not normal gives you a feeling that things might get worse. And that's what you're going to be telling the relatives.
Yes.
Fortunately, it doesn't mean that you just have a complete twist. Sometimes you can have more than one twist. So you don't want that to happen. And in testicular torsion,
Yes.
as you rightly said, speed is of the utmost. If you can get it, you'll get it done quickly. So the advantage of the Doppler tells you what to do. And then looking at this Doppler, you can, with reasonable accuracy, say that probably the testis can be saved. So that's your aim. You want to, therefore you want to do distal cord is partially twisted and all the rest of it can go completely twisted. Again, one more twist. It all depends on how you answer the examiner at this point and with what degree of confidence you're speaking about it. Because ultimately that's what he wants to know. How are you going to tackle the situation with the relative?
The parent says the only son, sir, and now the pain is relieved. Still you want to explore?
Yes, it has to be explored, sir.
No, you have to convince me I'm the father.
The cord appears twisted. He had earlier episode of the same, so it may further aggravate and cause.
Now it is relieved.
So it may happen again, sir. If the testis is prone for the torsions, and the fixing would solve the later episodes of torsion and.
Are you going to do anything on the opposite side?
The opposite side also will be fixed. Orchidopexy has to be done.
See, Saurabh, the question that Prabhu asked you was, this is the only son. The father says there is no pain. So you have to think out of the box. You have to think of not only from the medical side, but from the social side also. Suppose this boy goes off somewhere else. He goes off to his village. Or he's studying in a hostel and something happens. And, things can get out of hand at any point. And then he may not have access to emergency services. And your only son will lose one testicle. And it's quite possible that the other testicle also may be defective in such a situation. And therefore, you may not have progeny at all.
Yes.
What is left for you? You got to think out of the box and tell these fellows. Obviously, the father is hell-bent on not getting anything done for his son because it's testis. The scrotum is a very important organ for all these fellows, And anything there, they will be very concerned. So you have to bring that social angle into it in a nice way and tell them. Don't you see this in your clinical work? You know, the fellow
Yeah,
studying in the hostel or he's studying in the school and somewhere in some back of beyond, he has some pain, intermittent pain. It's a standard story, this one.
See, you have to speak like a consultant. You should look confident when you are saying. If you want, you give the numbers, the percentages, all those things, and you have to convince the opposite party that you are in safe hands. Otherwise, you will go for another opinion.
But
So you have to speak all this pathophysiology in simple language to the parents. In terms of times, 4 hours, partial torsion getting retorted. All these things has to be explained. What you do during exploration, you will see the testes, you'll untort it. And then your opposite side also needs to be fixed. If it is on this side, it can happen on the other side. We'll fix it so that this problem does not occur again.
What is clapper bell deformity? Have you heard of clapper bell deformity?
so the clapper bell deformity, it's, the testis lies horizontally, sir, and the epididymis.
Hey, that is not a acute problem. It is a developmental.
It's a free-lying testis with on the cord. So the cord there is increased chances of. Sir, the long epididymis causes. So, yeah, the horizontal.
Is it only the testes and the epididymis, or is there something else or some other component to it? You don't take that into account so often, but is there another component to it? Is the testis anchored in any place other than the cord?
No, sir, I don't know about the third point, sir.
Have you heard of gubernaculum?
Yeah, I told sir gubernaculum, sir.
Yeah, you did. Yeah. So what happens to the gubernaculum in the clapper bell?
It fixes the testis to a scrotal base, sir. So,
it is lax. Okay, it is lax.
The types of torsion.
What was done?
This is the last slide, right?
Last slide. Okay. No intraoperative slides.
Oh,
I think deleted.
no, it is there.
Okay.
Total exploration was done and bilateral orchidopexy was done, sir.
Yeah, see, these things you take photographs. For these teaching sessions, it's good for us to have them.
Yeah, I have put it.
Yeah, there you are.
It is there, sir.
I was surprised when you said got deleted. Yeah. See, since we are running out of time, we'll just sum it up. You look at the testis, it's healthy, the tunica is lustrous. If there is ischemia, you'll find the tunica looks dull. Often you'll find on the tunical surface those small vessels that you can see are thrombosed, you can make out they are thrombosed. The cord will be non-pulsatile, will be bluish. The testis also can be bluish or pale depending on the severity and the duration of the torsion, right? And when you rotate the testis to eliminate the torsion or detorsion as it is called, please make sure that you align the cord and the testis properly before you do that, because we could turn it the other way and make it worse. And finally, one question to Saurabh. Saurabh, where will you anchor the testis?
Sir, these best is, sir, the subdartus pouch, sir. However, we can anchor in the median raphe also.
Will you anchor it at one point or?
Sir,
Just leave it there.
No, sir, we anchor it, sir.
Suppose you put in the subdartus pouch.
Yes, sir.
Will you anchor it anywhere else or just?
Yes, we anchor.
Ideal that you put in the subdartus pouch so that it doesn't flip around the place. But if you don't, and by chance if you just put it back to where it belongs, then you'll have to anchor it so that it doesn't twist again.
Yes, sir.
You have the 4-point fixation, the 2-point fixation. Most people recommend that you use non-absorbable suture material to do it. But it stays which stays there for much longer, and therefore you can use that. Otherwise, many people use proline. Okay, so, and you have to fix the tunica at the beginning to the inside of the scrotal surface, and to the scrotal tissue, so that it doesn't move around. Most people will do a 4-point fixation, so that it just stays there.
Yes.
It's very clear that you guys need to go back and read about ultrasound of the testes.
Yes.
Huh?
Yes.
Human is not the only thing that happens here. There are lots of other inflammatory conditions more important. So just go and brush up because it is. From the question that Dr. Mohan asked, I think there's still a lot of lacuna to understand.
Sir, this one, maybe in the next class we can discuss for 10 minutes, sir. I mean, it's another condition where we generally require urgent.
Can we take it next time?
Yes, sir.
We're already past 9:05.
Yes, sir. Okay, sir.
So thank you all for this week. We'll begin with that next week.
Sure, sir. Okay, sir.
Okay, make sure that you have the images and whatever else you want to discuss.
Right, sir. Okay, sir.
Okay. And if Dr. Pramod can join in, it might be interesting.
Sure, sir. Okay, sir.
Okay. Thank you.
Thank you, sir.